I work at Nepean Hospital, which is the foothills of the Blue Mountains in Sydney. I've been there about 12 years and it's been a really rich experience. My time that's been there, yes. And probably that whole time I've been using Convexity. And it's probably a part of my natural kit. That's what I use, you have your flat and you have your Convexity. And it's really important to understand the types of patients that are going to have Convexity. And hopefully, I can share that a little bit further on. I mean, there are the firm Convexity. You can get shallow and you can get deep, you can get soft. You can also get Convexity where it's quite close to the aperture, and you can get Convexity where it's a bit further, wider out the side. Yeah. So, and that's certainly involved the softer and the different types of Convexity where it's actually placed on the actual appliance. That's changed of late. But I certainly know that Convexity has been in existence for a long time, but it's evolving so we can understand our patients a bit better. I think for me there are, with ileostomy, urostomy and colostomy, sometimes people think that you always need to have Convexity on a ileostomy and a urostomy. It often depends on their abdominal contours, the type of geography that they've got, as to whether you actually do that. Even with colostomies, I find you might be able to put them in a Convexity straight away because they might need it because of various circumstances. But in 6 months on reassessment, maybe they don't need it anymore. So I think it's important to constantly reassess. When you look at the stoma, you really need to look at where the lumen is. How close is that stoma and the lumen entrance to skin level? So when you first assess a patient, sometimes you might be assessing them straight after theatre, but really you really need to assess them when they're sitting, because that's when you're going to see the abdominal folds. Initially after surgery, you'll find that their abdomen is quite swollen and edematous, so things mightn't necessarily show themselves straight away. But looking at the stoma, and particularly if you put some pressure around where the stoma is, you'll see whether the impact of Convexity is going to make a difference. So there has been a tool in existence where it actually puts pressure around the stoma, and you can do it with your hands, to see whether your stoma mouth will actually pop up a bit better. Because you really want to have a bit more of a spout, especially ones that are quite low, so that the contents can get into the bag. So if you can put a bit of pressure around there by using Convexity, then that will make a better effect. Sometimes you've got to be careful, because if a person, you can look at abdomens and you can have a stoma that is well spouted and looks like a textbook. It's fantastic. But the abdominal, the actual abdomen, if it's really soft, you'll find that it's like the intestinal movement can actually dislodge the stoma, so that it's not very rigid, it's not very supportive. So in situations like that, you really need to have something that's firm, and you might need accessories like a belt as well. So you assessing the abdomen, whether it's soft or whether it's hard. I've actually had other patients who've got a really firm abdomen. They're very fit, they go surfing, they play rugby. It's really firm, and you try and put Convexity there, and it's a bit like that's the abdomen, and you're trying to put Convexity, and it's just not going to work. So you really need to assess as to what you're looking at and what's required. I think basically what you're looking at is you don't want to have leaks. And it's one thing is to have a stoma that is spouted, or maybe it's not necessarily that spouted that well, but you need to, you want to look at the adhesion, and it's a bit like looking at physics. You need to look at what else is needed to give the leverage, to give it the support that you need. Some companies have what they call body fit, where it actually moves, and that the actual structure of it sort of moves a bit more with the body. Sometimes you need some that are a bit more softer, that can work with the patient, and firm. Even I have patients that sometimes the stoma is actually retracted back. Convexity can work really well for that. I've actually had patients who've actually had where the ureter comes out through the umbilicus, and I think to myself, well, that's the worst case scenario. You've got all those creases, all those grooves. But Convexity can actually go into that and actually have a really good seal. So sometimes you need to look outside the box and thinking that, will this make a difference? I think you need to have somebody else who can give them some visual aids, show them how it makes a difference, help them to look at the stoma, to reassess the stoma, to look at the creases and folds that could impact on causing that to become loose. So you really need someone, I think there's nothing better than actually to see it. So if you can see different situations, and then also the practical side of just putting your hands around the stoma to see when pressure is put on, will it make a difference? Sometimes you think, well, the lumen, the entrance is right close to skin level, but when you put pressure on it, it's not going to make any difference at all. And the skin is and the abdomen and the muscles are quite firm. Yeah, so I think combined as a good guideline, that's excellent, but I think also having somebody who can also show you and demonstrate some of those things would be helpful too.